Hello and welcome to part 3 of the fundamentals of advanced pharmacology. My name is Lorraine Hu and I will be presenting on pharmacodynamics in this PowerPoint presentation. I have made other videos as well. If you enjoyed my videos and enjoyed learning about advanced pharmacology, please subscribe to my YouTube channel for further videos. Thank you so much. We're going to begin with recap of part 1 and part 2 of fundamentals of advanced pharmacology. We talked about drug movements within the body, passive diffusion, facilitated diffusion, and active transport. We defined pharmacokinetics. It is what the body does to the drug or the action of the body on the drug. The movement of a drug within the body depends on the ionization state of the drug molecule. We discussed ADME extensively, the way drugs are administered, with oral drugs being the most convenient way for patients to take the drug. Oral medications are subjected to first-pass metabolism by the liver, which alters bioavailability. And intravenous is rapid with 100% bioavailability, avoiding first-pass metabolism. Distribution of a drug is determined by several factors, such as blood flow to the organ, the solubility of a drug, and the level of binding of drugs to proteins within the blood. Sites of metabolism of most drugs are metabolized by the liver. The kidneys are another important site of metabolism. The enzymes of degradation for a small number of drugs are spread widely throughout other tissues, including the blood and the wall of the GI tract. Elimination determines the duration of action for most drugs, where an example of the first-order rate of elimination is proportional to the drug concentration, resulting in a constant half-life elimination. Pharmacodynamics is what the drug does to the body. It involves drug actions on target cells and the resulting alterations in cellular biochemical reactions and functions. Pharmacodynamics is the study of the relationship between the concentration of a drug in the systemic circulation and the biologic response that occurs, often termed the dose-response relationship. A dose-response curve can be drawn by plotting the concentration of the drug on the x-axis and the response on the y-axis. The minimum effective concentration is the lowest dose at which a desired response is noted. A concept applied to the effect of antimicrobials is minimum inhibitory concentration, meaning the lowest dose at which the antimicrobial inhibits visible growth of a microorganism overnight. The same dose of a drug often results in a different plasma concentrations among individuals. This difference is secondary to individual differences in pharmacokinetic parameters. For example, the onset, intensity, and duration of response and individual experiences depend on both the dose of the drug administered and the pharmacokinetics of the drug in that individual. Two important parameters can be calculated in drawing dose-response relationship curves for drugs. Potency is the concentration at which the drug elicits 50% of its maximal response. Efficacy is the maximum response produced by the drug. A clinical example of a study of pharmacodynamics is recording changes in blood pressure when a patient is being treated with antihypertensive medications. According to this concept, there is a drug receptor located within the target organ tissue. When a drug molecule finds and targets and attaches to the receptor target, it forms a complex with that target that causes the biologic response, which is the specific mechanism of action of that drug. The site and extent of drug action on body cells are determined primarily by specific characteristics of receptors and drugs. Receptors vary in type, location, number, and functional capacity. For example, many different types of receptors have been identified. Most types occur in most body tissues, such as receptors for epinephrine, whether received from stimulation of the sympathetic nervous system or administration of drug formulations. And then there's receptors for growth hormone, thyroid hormone, and insulin. Some occur in fewer body tissues, such as receptors for opioids in the brain and subgroups of receptors for epinephrine in the heart. That's the beta-1 adrenergic receptor. And then you have the receptors in the lungs, which are beta-2 adrenergic receptors. Receptor type and location influence drug action. The receptor is often described as a lock into which drug molecules fit as a key, and only those drugs able to bond chemically to the receptors in a particular body tissue can exert pharmacologic effects on that tissue. Thus, all body cells do not respond to all drugs, even though virtually all cell receptors are exposed to any drug molecules circulating in the bloodstream. The number of receptor sites available to interact with drug molecules also affect the extent of drug action. Drug molecules must occupy a minimal number of receptors to produce pharmacologic effects. Thus, if many receptors are available, but only a few are occupied by drug molecules, few drug effects occur. In this instance, increasing the drug dose increases the pharmacologic effects. Conversely, if only a few receptors are available for many drug molecules, receptors may be saturated. In this instance, if most receptor sites are occupied, increasing the drug dosage produces no additional pharmacologic effect. Drugs vary even more widely than receptors because all drugs are chemical substances. Chemical characteristics determine drug actions and pharmacologic effects. For example, a drug's chemical structure affects its ability to reach tissue fluids around a cell and bind with its cell receptors. Minor changes in drug structure may produce major changes in pharmacologic effects. Another major factor is the concentration of drug molecules that reach receptor sites in body tissues. When drug molecules chemically bind with cell receptors, pharmacologic effects result from agonism and antagonism. Agonists are drugs that produce effects similar to those produced by naturally occurring hormones neurotransmitters and other substances of endogenous regulators activate the receptors to which they bind. All of these compounds are considered agonists. When drugs act as agonists, they simply bind to receptors and mimic the actions of the body's own regulatory molecules. And agonists may accelerate or slow normal cellular processes depending on the type of receptor activated. For example, epinephrine-like drugs act on the heart to increase the heart rate, and acetylcholine-like drugs act on the heart to slow the heart rate. Both are agonists. Antagonists are drugs that inhibit cell function by occupying receptor sites. This strategy prevents natural body substances or other drugs from occupying the receptor sites and activating cell functions. Basically, antagonists have virtually no effects on their own on receptor function. Although antagonists do not cause receptor activation, they most certainly produce pharmacologic effects by preventing the activation of receptors by endogenous regulatory molecules. For example, antihistamines are histamine receptor antagonists that suppress allergy symptoms by binding to receptors for histamine, thereby preventing activation of these receptors by histamine released in response to allergens. After drug action occurs, drug molecules may detach from receptor molecules, and this is actually a chemically that's binding that is reversible. So the drug molecules may detach from the receptor molecules after the drug action has taken place, and then they return to the bloodstream and circulate to the liver for metabolism and the kidneys for excretion. It is important to note that the response to an antagonist is determined by how much agonist is present. Because antagonist acts by preventing receptor activation, if there is no agonist present, administration of an antagonist will have no observable effect. The drug will bind to its receptors, but nothing will happen. On the other hand, if receptors are undergoing activation by agonist, administration of an antagonist will shut the process down, resulting in an observable response. An example is the use of opioid antagonist naloxone, Narcan is the other name, which is used to block opioid receptors in the event of an opioid overdose. Receptors are dynamic cellular components that can be synthesized by body cells and altered by endogenous substances and exogenous drugs. For example, prolonged stimulation of body cells with an excitatory agonist usually reduces the number or sensitivity of receptors. As a result, the cell becomes less responsive to the agonist. This is a process called receptor desensitization or downregulation. Prolonged inhibition of normal cellular functions with an antagonist may increase receptor number or sensitivity. If the antagonist is suddenly reduced or stopped, the cell becomes excessively responsive to an agonist. This is a process called receptor upregulation. These changes in receptors may explain why some drugs must be tapered in dosage and discontinued gradually if withdrawal symptoms are to be avoided. Few drugs act by mechanisms other than combination with receptor sites on cells. Drugs that do not act on receptor sites include the following: antacids, which act chemically to neutralize the hydrochloric acid produced by gastric parietal cells and thereby raise the pH of gastric fluid. Osmotic diuretics, for example, mannitol, which increase the osmolarity of plasma and pull water out of tissues into the bloodstream. Drugs that are structurally like nutrients required by body cells, and these are the purines and the pyrimidines. So the nutrients that are required by body cells and that can be incorporated into cellular constituents such as nucleic acids, which interfere with normal cell functioning. Several anti-cancer drugs act by this mechanism. Metal chelating agents, which combine with toxic metals to form a complex that can be more readily excreted. Variables that affect drug actions are patient-related variables and how they respond to drugs. Drug-related variables such as dosage refers to the frequency, size, and number of doses. It is a major determinant of drug actions and responses, both therapeutic and adverse. Routes of administration affect drug actions and patient responses by influencing absorption and distribution. For rapid drug action and response, the intravenous or IV route is most effective because the drug is injected directly into the bloodstream. For some drugs, the IM route also produces drug action within a few minutes because the muscles have a large blood supply. The oral route usually produces slower drug action than the parenteral route. Absorption and action of topical drugs vary according to the drug formulation, whether the drug is applied to the skin or mucous membrane, and other factors. A few drugs are used therapeutically to decrease food absorption in the intestinal tract. For example, orlistat decreases absorption of fats from food and is given to promote weight loss, and ezetimibe, which is Zatia as the other name, decreases absorption of cholesterol from food and is given to lower serum cholesterol level. However, most drug-diet interactions are undesirable because food often slows absorption of oral drugs by slowing gastric emptying time and altering GI secretions and motility. Some foods contain certain substances that react with certain drugs. One such interaction occurs between tyramine-containing foods and monoamine oxidase inhibitor drugs, so the MAOIs. The tyramine causes the release of norepinephrine, a strong vasoconstricting agent, from the adrenal medulla and sympathetic neurons. Normally, norepinephrine is quickly inactivated by the monoamine oxidase. However, because the MAOI inhibitor drugs prevent inactivation of norepinephrine, ingesting tyramine-containing foods with an MAOI inhibitor may produce severe hypertension or intracranial hemorrhage. MAOI inhibitors include the antidepressants such as isocarboxazide and phenelzine, and then the anti-Parkinson's drug, selegiline and rasogiline. Another interaction involves grapefruit juice. Grapefruit contains a substance that strongly inhibits the metabolism of drugs normally metabolized by the cytochrome P3A4 enzyme. By inhibiting the cytochrome P3A4 can cause an increase in plasma levels of drugs, adverse drug reactions, and or toxicity. This effect greatly increases the blood levels of some drugs, that is the widely used statin groups of cholesterol lowering drugs, and the effect lasts for several days. Patients who take medications metabolized by the cytochrome 3A4 enzyme should be advised against eating grapefruit or drinking grapefruit juice. How much grapefruit juice does it take? Is it just the juice, or does a grapefruit eaten at breakfast have the same effect? What about the different types of grapefruit? Both grapefruit and grapefruit juice irreversibly inhibit cytochrome 3A4, so new enzymes must be synthesized before normal function is restored. Thus, 30% of the inhibitory effect is still present 24 hours after ingestion of a single 8-ounce juice of normal strength grapefruit juice. It is recommended that medications affected by grapefruit juice not be taken until 72 hours after the last glass of grapefruit juice, as the inhibition may persist for 3 days or more after eating the fruit or drinking its juice. Unfortunately, for grapefruit juice lovers, the effect is the same if they drink white, pink, or ruby red juice. Here's a table that I made up with clinical effects of increased serum concentrations of drug when taken with grapefruit juice, and the effects are on the right hand side of the screen, and on the left hand side are the drugs that have significant interaction with grapefruit juice. And I just chose a handful of commonly used drugs in clinical practice. So antiarrhythmics here, see amiodarone, okay, and the clinical effects is on the right hand side: thyroid, pulmonary, liver injury, cardiac arrhythmias, bradycardia, prolonged QT syndrome. There's another one, but it's not that commonly used, is quinidine. You'll see clinically, you'll see Torsades D point. And then the next drug family here is the benzodiazepines. I just put a few here, okay, diazepam, midazolam, halcyon. So you're going to see increased CNS depression for when taken with grapefruit juice, and these drugs cause that anyway, even if you don't drink grapefruit juice. So here's calcium channel blockers, okay, verapamil, felodipine, and narcardipine. You'll see flushing, peripheral edema, headaches, hypotension, tachycardia, and then the CNS depressant drugs, Tegretol, Zoloft. With Tegretol, you'll see ataxia, drowsiness, nausea, vomiting, tremors. With sertraline, that's Zoloft, you'll see serotonin syndrome, and the side effects are listed here: nausea, vomiting, diarrhea, agitation, increased blood pressure, headaches, tremors, high fever, seizures, and rhabdomyolysis. And then last of all here, I put the statins down: Lipitor, atorvastatin, simvastatin, just the common ones, okay? Pravastatin, you will see increased statin levels, and that will probably possibly cause rhabdomyolysis. Drug-herb interactions are particularly difficult to assess. Most herbal products obtained over the counter are considered dietary supplements and therefore are not regulated as drugs. Thus, there is wide variation in the pharmaceutically active compounds in different herbal preparations, and some may include components that are harmful. Nevertheless, adverse effects are known to occur when specific herbs and drugs are taken concurrently with regulated medications. Individuals taking warfarin can have increased bleeding if they take salvia or garlic preparation. Now, salvia miltoriza is also known as red sage. This was used widely in China to treat cardiovascular disease. Some of the most well-known herb-drug interactions are associated with the use of St. John's wort. This herb has been purported effectiveness for the treatment of individuals with depression. However, placebo trials of St. John's wort have been inconclusive, and meta-analysis have concluded that it might be effective for mild depression only. In addition, St. John's wort is an enzyme inducer and decreases the plasma levels of many drugs, including midazolam, digoxin, warfarin, and oral oxycodone. Women who are taking oral contraceptives can also experience breakthrough bleeding when St. John's wort is taken concomitantly with oral contraceptives, and this drug combination may interfere with the contraceptive effectiveness. Drug-to-drug interactions can occur whenever a patient takes two or more drugs. Some interactions are both intended and desired, as when we combine drugs to treat hypertension. In contrast, some interactions are both unintended and undesired interactions. When two drugs interact, there are three possible outcomes. Number one drug may intensify the effects of the other. Number two, one drug may reduce the effects of the other. And number three, the combination may produce a new response never seen with either drug alone. And I'm going to go into this a little bit more detail in the next slide. One drug may intensify the effects of the other. This could be good or bad, or it could be therapeutic or not therapeutic. So the first example would be therapeutic, which is good. Intensification of effects, that is therapeutic. The interaction between sulbactam and ampicillin represents a beneficial potentiative interaction. When administered alone, ampicillin undergoes rapid inactivation by bacterial enzymes. Sulbactam inhibits those enzymes and thereby prolongs and intensifies ampicillin's therapeutic effects. And then the second example, which is bad because of the increase in adverse effects when there were two drugs are put together. Okay, so intensification of effects that increase adverse effects would be interaction between aspirin and warfarin. Both aspirin and warfarin suppress formation of blood clots. Aspirin does this through antiplatelet activity, and warfarin does this through anticoagulant activity. As a result, if aspirin and warfarin are taken concurrently, the risk of bleeding would be significantly increased. One drug may reduce the effects of the other. Interactions that result in reduced drug effects are often termed inhibitory. Inhibitory interactions can be beneficial or detrimental. Inhibitory interactions that reduce toxicity are beneficial. Conversely, inhibitory interactions that reduce therapeutic effects are detrimental. Reduction of therapeutic effects would be interaction between propranolol and albuterol that represents a detrimental inhibitory interaction. Albuterol is taken by people with asthma to dilate the bronchi. Propranolol, a drug for cardiovascular disorder, can act in the lung to block the effects of albuterol. Hence, if propranolol and albuterol are taken together, propranolol can reduce albuterol's therapeutic effects. The use of naloxone to treat morphine overdose is an excellent example of a beneficial inhibitory interaction. When administered in excessive dosage, morphine can produce coma, profound respiratory depression, and eventual death. Naloxone blocks morphine's actions and can completely reverse all symptoms of toxicity. The combination may produce a new response not seen with either drug alone. The combination of alcohol with disulfiram, or antabuse is the other name for disulfiram, a drug used to treat alcohol use disorder. When alcohol and disulfiram are combined, a host of unpleasant and dangerous responses can result, called acetaldehyde syndrome. The symptoms are nausea, copious vomiting, flushing, palpitations, headaches, sweating, thirst, chest pain, weakness, blurred vision, and hypotension. So hypotension would be actually very severe hypotension. Blood pressure may ultimately decline to shock levels. In its most severe manifestation, the acetaldehyde syndrome is life-threatening. Possible reactions include marked respiratory depression, cardiovascular collapse, cardiac arrhythmia, MI, acute congestive heart failure, convulsions, and death. So clearly the acetaldehyde syndrome is not simply unpleasant, but the syndrome can be extremely hazardous and dangerous for the patient. So this must be avoided at all cost. However, these effects do not occur when disulfiram or alcohol is used alone. Interactions that can increase the therapeutic or adverse effects of drugs include the following. Additive effects, which occur when two drugs with similar pharmacologic actions are taken. For example, ethanol and sedative drugs increases sedative effects. Synergism, which occurs when two drugs with different sites of or mechanism of action produce greater effects when taken together. That is, an example is acetaminophen and codeine that increases the analgesic effects. Interference by one drug with the metabolism of a second drug, which may result in intensified effects of the second drug. For example, cimetidine inhibits the cytochrome P1A, cytochrome P2C, and cytochrome P3A drug metabolizing enzymes in the liver and therefore interferes with the metabolism of many drugs like benzodiazepines, hypnotic drugs, and some drugs uh, that are cardiovascular drugs. When these drugs are given concurrently with cimetidine, they are likely to cause adverse and toxic effects because the blood levels of the drugs are higher. The overall effect is the same as taking a larger dose of the drug whose metabolism is inhibited or slowed. Displacement. That's a drug with strong attraction to protein binding sites may displace a less tightly bound drug. So displacement of one drug from plasma protein binding sites by a second drug, which increases the effects of the displaced drug. This increase occurs because the displaced drug, freed from its bound form, becomes pharmacologically active. The overall effects is the same as taking a larger dose of the displaced drug. For example, aspirin displaces warfarin and increases the drug's anticoagulant effects. Interactions in which drug effects are decreased include the following. An antidote drug which can be given to antagonize the toxic effects of another drug. For example, naloxone is commonly used to relieve respiratory depression caused by morphine and related drugs. Naloxone molecules displace morphine molecules from the mu receptor sites on the nerve cells in the brain so that the morphine molecules cannot continue to exert its depressant effects. Decreased intestinal absorption of oral drugs, which occurs when drugs combine to produce non-absorbable compounds. For example, drugs containing aluminum, calcium, or magnesium bind with oral tetracycline to decrease its absorption and therefore its antibiotic effect. Activation of drug metabolizing enzymes in the liver, which increases the metabolic rate of any drug metabolized mainly by that group of enzymes and therefore decreases the drug's effect. Several drugs such as phenytoin, rifampin, and cigarette smoking are also known as the enzyme inducers. Both illness and some normal changes in health status can affect the pharmacokinetics and pharmacodynamics of a given drug. Gender differences in drug metabolism may relate to several factors. Women are generally smaller in stature and weight than men. Consequently, when women are prescribed the standard dose for men, they are often found to have higher plasma drug concentrations. In addition, individual differences in water and fat content can affect drug metabolism, as some drugs are more hydrophilic or lipophilic. Women have a slower gastrointestinal transit time during the luteal phase of the menstrual cycle and during pregnancy, which can also affect drug absorption. Women have a 50 to 75% higher risk for having an adverse event as men, in large part due to these many gender-related physiologic variations. Metabolic differences between the sexes have been noted for several drugs. This suggests that hormonal activity might affect the activity of certain cytochrome P450 enzymes. For example, women metabolize diazepam, prednisone, caffeine, and acetaminophen slightly faster than their male counterparts. Conversely, men metabolize propranolol, chlordiazepox, which is Librium is the other name for it, and lidocaine, and other steroids faster than women. During pregnancy, a woman's reduced gastrointestinal motility and increased gastric pH affect drug absorption. Drug distribution can change because the maternal plasma volume increases by 50% in pregnancy. Serum albumin binding capacity is decreased during pregnancy, which results in an increase in unbound active drug. Maternal hormones can affect drug metabolism by enhancing or inhibiting metabolism of various drugs. Drug excretion may also be affected due to the increase in renal blood flow. A patient with liver disease and tuberculosis will be unable to take some anti-tubercular drugs due to their hepatic toxicity. Congestive heart failure decreases hepatic blood flow by reducing cardiac output, which alters the extent of drug metabolism. An alteration in production of the major drug-binding protein albumin can also alter the ratio of bound to unbound drug. Thus, a decrease in plasma albumin can increase the fraction of unbound or free drug, which then becomes available to exert more of the pharmacological effect. The reverse is true when plasma albumin increases. Patient-related variables. The effects of age on drug actions are especially important in neonates, infants, and older adults. In children, drug actions depends largely on age and developmental stage. During pregnancy, drugs cross the placenta and may harm the fetus. Fetuses have no effective mechanism for eliminating drugs because their liver and kidney functions are immature. Newborns from birth to 1 month also handles drug ineffectively. Drug distribution, metabolism, and excretion differ markedly in neonates, especially premature infants, because their organ systems are not fully developed. Older infants reach approximately adult levels of protein binding and kidney function. Although pharmacologically similar to adults, children complete maturation of their liver develops by 1 year. But they do differ in one important way. They metabolize drugs faster than adults. Drug metabolizing capacity is markedly elevated until age 2 and then gradually declines. Babies are born with immature blood-brain barrier. However, children reach an adult level of expression at 3 months to 6 months of age. In older adults, 65 and older, physiologic changes may alter all pharmacokinetic processes. Changes in the GI tract include decreased gastric acidity, decreased blood flow, and decreased motility. Despite these changes, however, there is little difference in drug absorption. Changes in the cardiovascular system include decreased cardiac output and therefore slower distribution of drug molecules to their sites of action, metabolism, and excretion. In the liver, blood flow and metabolizing enzymes are decreased. Thus, many drugs are metabolized more slowly, have a longer action, and are more likely to accumulate with chronic administration. In the kidneys, there is decreased blood flow, decreased glomerular filtration rate, and decreased tubular secretion of drugs. All these changes tend to slow excretion and promote accumulation of drugs in the body. Impaired kidney and liver function greatly increase the risk of adverse drug effects. In addition, older adults are more likely to have an acute and chronic illness that require the use of multiple drugs or long-term drug therapy. Thus, possibilities for interactions among drugs and between drugs and diseased organs are greatly multiplied. Body weight affects drug action mainly in relation to dose. The ratio between the amount of drug given and body weight influences drug distribution and concentration at sites of action. In general, people who are heavier than average may need larger doses, provided that their renal, hepatic, and cardiovascular functions are adequate. Recommended doses for many drugs are listed in terms of grams or milligram per kilogram of body weight. Pharmacogenomic variations. The prescribers orders drugs to cause effects in recipients. However, when some people receive the same drug in the same dose by the same route and in the same time interval, they may experience inadequate therapeutic effects or unusual or exaggerated effects, including increased toxicity. These inter-individual variations in drug response are often attributed to genetic heritage, which produces differences in drug metabolism. The study of genetic variations in drug response is called pharmacogenomics. So I will be covering genetics and pharmacogenomics in another PowerPoint presentation. So stay tuned for that. Please subscribe and you will get notification when it is available. Thank you. Genetic factors, essentially the metabolism rate for certain drugs can be slower or faster in some individuals based on genetic determinants. The primary pharmacokinetic processes affected by genetics occur during drug metabolism because the genes that encode for the cytochrome P450 enzymes have many polymorphisms that affect the function of these enzymes. In general, cytochrome P450 enzyme polymorphism results in a person being either a poor or slow metabolizer, an intermediate metabolizer, an extensive metabolizer, and an ultra-rapid metabolizer of a given medication. Persons who are poor metabolizers will have significantly elevated plasma concentrations of a drug and a greater risk of toxicity than those who are extensive or ultra-rapid metabolizers when given the same dose. If a medication must be metabolized first so that the metabolites is the active drug, a poor metabolizer may have a much weaker therapeutic response. In contrast, a polymorphism that involves duplicates of cytochrome P2D6, which can result in as many as 13 copies of this gene, becomes an ultra-rapid metabolizer of drugs that are metabolized by the cytochrome P2D6. In this case, maintaining therapeutic drug levels may be difficult. Identification of the therapeutic index sets the stage for considering bioequivalence. Bioequivalence is determined by comparing the mean bioavailability of two drug products in multiple samples. If the mean bioavailability of one drug is within 80% to 125% of another drug, the two are determined to be bioequivalent and can usually be substituted for each other. However, bioequivalence does not guarantee therapeutic equivalence. Because bioavailability depends on multiple individual factors, levothyroxine is available in several brand names and generic formulations. Whether any of these are interchangeable is in dispute. Levothyroxine has a narrow therapeutic range, so tight control of plasma drug levels is important. Otherwise, symptoms of hypothyroidism or toxicity will develop. To maintain good control, all pills a patient takes must produce the same levothyroxine levels. Accordingly, if a patient switches from one product to another, the new product must be bioequivalent to the old one. Another example is an elderly patient with renal compromise may have a pharmacodynamic profile that allows her to metabolize one formulation of digoxin to obtain a therapeutic plasma level, but another formulation may result in subtherapeutic plasma level. If the prescriber does not want the pharmacy to substitute one drug for another that has been determined to be bioequivalent, the words "no substitution" must be written on the prescription pad. So thank you very much. This actually concludes the PowerPoint presentation on pharmacodynamics, and I plan on making some more videos, a PowerPoint presentation on pharmacogenomics, so stay tuned and please subscribe so you can get notification that my videos are available to view. Thank you so much.